Oh my God, she's
Thanks.
gorgeous, man. I can't wait to come and meet her. Anyway, we'll do
Right,
that soon. All right.
We are live. Good morning, everyone. And this is a strange experience, talking to lots of people that I can't actually see. But welcome to our webinar. We're really excited to present you this webinar this morning, and really excited about the topics we're going to cover. My name is Richard Stantiford. Obviously, you all know Dr Aseem Malhotra, who is our guest speaker. And just a little bit of background, first of all, before I hand over to Aseem. So my background is basically, I'm an exercise physiologist. I specialize in cardiac rehabilitation. I've been running programs for many years, nearly almost 18 years, all over Sussex. And that was obviously pre-COVID. And now what I'm doing is I've taken some of that online, and I'm still working with patients that really wanted to continue with some structure, particularly around exercise, but also wanted advice about other aspects of lifestyle. So I got to become friends with Aseem when I first basically came onto Twitter and started following Aseem's work. And obviously read the Piopi diet, which was a bit of a game changer for me, because after I read that book, that completely changed a lot of the things that I was doing, particularly around diet. Because I was quite late into the whole low carb movement, and I was basically taught by the BACPR, and they were kind of following the British Heart Foundation's advice on diet, which was traditional low fat, fairly high carb diet. So it was a revelation to me to find out about, that wasn't perhaps the best route forwards. So ever since the Piopi diet and the countless publications that I've read of Aseem's, I'm a bit of a convert, and now following a Mediterranean style diet, which is on the low carb side, and feel a lot better for it. Before I introduce Aseem, I've also got a personal interest in this, because I have heart disease on both sides of my family. My father has had multiple stents, the first one in his 50s, and my mother's had stents as well in her coronary arteries. And so I've got it both sides. And thanks to the work of Aseem and Ivor Cummins, I put myself forward for a coronary artery calcification scan, which I was hoping was going to be a 0, but in actual fact showed that I had a fair amount of calcium in my coronary artery. So that was a real shock for me. So I'm now on a bit of a journey with Aseem's guidance to try and halt or reverse my own coronary disease. Obviously, I'm completely asymptomatic, but I know that there's something there. So we're going to keep an eye on that over the coming years. But anyway, that's enough about me. I know that you've all come to see Aseem this morning, and I'm delighted that he's here. This has been a long time coming. Aseem is someone that I look up to, not only as a friend, but with all the amazing work that he's done. So to introduce Aseem now, obviously you all know that he's a consultant cardiologist, done a lot of work with the NHS and also private work as well. He's also become a professor of evidence-based medicine, and he was the founding member of Action on Sugar, and coordinated the Choosing Wisely campaign by the Academy of Medical Royal Colleges. He's published countless articles, all of which I've read. Best-selling book, The Piopi Diet, and obviously the 21-day immunity plan, which we'll talk a little bit around today as well. So I could carry on reading out Aseem's list of his own personal bio, but that would take half of the webinar. So I'm going to hand over to Aseem now. Thank you, Aseem.
Thanks, Richard. Okay, so let me get to my screen for the presentation. So thank you everybody for attending, and for all those who are going to see the recording. We hope that you will get quite a lot out of this, both the presentation that I'm going to go through over the next 30 to 40 minutes, and then we're going to have quite a lot of time, up to maybe an hour and a half, hopefully, of answering people's questions. I think what's important to mention, just to be very clear, in keeping with being ethical, is that we are empowering and informing you, and we can take part in obviously discussions and guide people as best as possible. But this isn't a substitute for medical advice that you will get from your own doctor, and therefore anything that's discussed here, certainly if you're going to make some drastic changes in terms of medical management, and some of this also may well relate to cholesterol and statins, which I'm going to discuss, you must talk to your own physician, your own doctor about that first. So a little bit about me briefly. I think it's important for people to understand my background, my experience, my expertise, and also what motivates me, which I think is crucial to trying to get your head around, or get to grips with why some of the things I say may be, contrary to a lot of, beliefs, and certainly contrary to what people believe conventional medicine, or certainly their experience of conventional medicine is. So I'm a consultant cardiologist, NHS trained, almost 2 decades working in the NHS, and I've probably managed, treated tens of thousands of patients in that time. I specialize in cardiology, that's my area of interest, but I also have a background in general medicine as well. I was given a visiting professorship in Brazil in evidence-based medicine in relation to all my medical journal publications and my advocacy work. And I'm also, a member of the board of trustees of the King's Fund, which is an independent health think tank that advises government on health policy. So for me, it's not just about my clinical work and my patients are really who inform and inspire my work and sustain my work, actually, through the clinical practice, which will never, for me, is at the heart of everything I do. But it's also about how can what is my role in helping to change, influence health policy. And I think hopefully by the end of this talk, you'll understand why we need to make some really drastic changes in the healthcare system, that we're operating in at the moment, which is failing, sadly. So the 7 Nolan principles actually was developed initially, initiated by John Major when he was Prime Minister in 1994. And it was, he set up the Committee on Standards in Public Life. You can look this up, you can Google it. And the reason I'm mentioning this is actually there are certain ethical principles that all those who have a role in public life should be adhering to. So this includes, doctors, teachers, even politicians. And when I'm going to go through this list briefly, but I think one of the things that I think may appear obvious to you is that clearly many people, most people, are either not adhering to it, or more importantly, probably because of the system that we're in or operating in, it's very difficult, or certainly more challenging, for people to adhere to all these principles. I certainly always think about this with everything I do, whether it's writing an article, whether it's trying to publish something in a medical journal, whether it's speaking out on social media or through the mainstream media. So those are selflessness, objectivity, integrity, accountability, honesty, openness, and leadership. And leadership also means actively promoting the principles, but being willing to challenge poor behavior wherever it occurs. And I think all of us as human beings, as people that use the healthcare system, that go to see doctors, we would hope and expect those people in public life and healthcare professionals as well, there's not just doctors, nurses, allied healthcare professionals, we would hope that those people that we trust with our health would be following all of those principles. Rudolf Virchow, pioneering physician, who did a lot of great work, a German physician in the 19th century. He actually also, took a view which I agree with personally, because I think certainly a lot of people think that, there is this phrase of stay in your lane. There are some people that challenge, why are doctors going outside the hospital grounds to, influence politicians, for example. But for me, medicine is, as Rudolf says, it's a social science, and politics itself is nothing else but medicine on a large scale. And our role in medicine as a social science is has the obligation and duty to point out problems and attempt their theoretical solution. And of course, politicians, you know, the practical anthropologist must find the means of their actual solution. And we've seen all of this, how COVID-19, the pandemic has kind of panned out. You've got you know, independent scientists, part of SAGE, for example. Then you've got political decisions being made by, you know, the government. They don't always marry with each other. But ultimately, it's our government that, you know, determines our laws and you know, so many things that we do with it within how we live, that actually there has to be some relationship there between medicine and politics. And of course, if our officials are not doing their job properly, certainly from my perspective as a doctor, I feel it's my duty to speak out and try and influence things so that we can make sure that our politicians are also adhering to the 7 Nolan principles. Okay, so how do we explain the current system, the healthcare system failure we're in? And the reason I'm mentioning this, it will help inform the rest of the talk when we talk about things like cholesterol and statins and we talk about lifestyle, is this is a very elegant you know, concept, but can help inform us and explain so many things that are wrong with the current system of healthcare at the moment, but even beyond that, about, you know, decisions that we make and who we vote for and the information that we gather to make decisions about so many things, you know, which we get from different sources, a lot of it on you know, from social media. So let's just talk about it from a healthcare professional's perspective. Our role, our duty is to improve patient outcomes, and we use our clinical expertise, our experience as healthcare professionals, the best available evidence, and last but not least is actually taking into consideration patient values and expectations. Now, if you just stop for a second and just think, understanding and accepting this concept, which I think is a very good and a pretty accurate you know, way of understanding how we can improve patient outcomes. If the evidence itself is incorrect or corrupted or commercially influenced, the best available evidence, and we're not actually taking into consideration patients' values and expectations, so, you know, lack of informed consent, then we're going to get bad outcomes. And in essence, that's what we've got in many ways in our healthcare system. So we are, you know, the healthcare system itself is failing, in my view, because we're not actually even adhering to evidence-based medicine. And just to give you an example, some estimates suggest that most of the published medical research is false. So let's just talk about that in a second. And the one of the most eminent scientists, medical scientists in the world, professor of medicine statistics at Stanford, John Ioannidis, he wrote a paper in 2004, published in PLOS One. It's open access, you can look at it. I mean, it's fascinating. And he actually wrote, you know, why most published research findings are false. And he gives lots of different factors involved in terms of studies that influence guidelines, that influence clinical decision-making in the consultation room. And there are so many biases and problems with those studies that, you know, he suggests there's so many things we can do better. One of the things he also says is that the greater the financial and other interests and prejudices in the scientific field, the less likely the research findings are to be true. And another paper he wrote more recently is called How to Survive the Medical Misinformation Mess. So having, you know, shared this with you, and some of you may know this already, and some of you may find this quite shocking, why is it still perpetuated? Why is this still a problem? Why have we not done anything about it? And the reason is because, you know, first and foremost, just to repeat that most published research is either not reliable, doesn't offer benefit to patients, or is actually not useful to decision makers. Now, this is a key issue here. Most healthcare professionals are not aware of this problem. Because if you're not aware of a problem, it's like in medicine, if you're not aware of a potential diagnosis or a disease or a condition, a patient comes to see, if you're not aware of the existence of it, you won't diagnose it. So we're not actually diagnosing the problem because we're not aware of its existence. And then many doctors lack the necessary skills to evaluate the reliability and usefulness of medical science. And a lot of that is because of the way we're trained in medical school. There's not a lot of time devoted to critical appraisal of research. And certainly there was nothing I learned in medical school that suggested that a lot of the research that's published is you know, influenced to such a large degree by the pharmaceutical industry that the results are very questionable at best. And then patients and families, we talk about the patient preferences and values, patients and families are then, they themselves lack relevant, accurate medical evidence and skill guidance at the time of medical decision making. So a lot of the medical decision making is then skewed from the doctor's perspective. and the doctor is making those clinical decisions on biased information, and it's very clear, it doesn't take a rocket science to work that out, then you're not going to get the best outcomes for that patient, and often, certainly not even close to getting the best outcomes in many instances. And then to add into all of this, you've got to understand medicine is not really an exact science. A lot of people have this belief, culturally, that medicine is an exact science, and it's not. There's a lot of uncertainty in medicine, and that's something that I think we need to be more honest with patients about. I'm always honest with patients about this as well. And it's always constantly evolving. So, I teach my medical students, I tell them that actually a lot of medicine is basically, it's an art, and information decision making is using, probabilities from research, but it's about then applying it to that particular individual. And every human being is different. They have different value systems. Things affect individuals differently, whether it's diet, whether it's stress. So I think we have to think a little bit more holistically when we practice medicine. But what David Sackett said, who was actually the founding father of the evidence-based medicine movement, he said half of what you learn in medical school will actually show to be either dead wrong or out of date within 5 years of your graduation. The trouble is nobody can tell you which half. So the most important thing you can do is to learn how to learn on your own. And I actually didn't know this or learn this at medical school. So this is something I came across, having graduated, done my postgraduate examinations. Having this level of healthy skepticism was not something that was in the forefront of my mind when it came to medical practice until I was at least 10 years qualified as a doctor. So if you think about that, and I'm somebody considered at the forefront of trying to make the changes to the system, most of the doctors probably wouldn't have this at their forefront of their thinking. And the reason that's important is it stops us being critical thinkers about the evidence that we have at the moment, but also can inhibit innovation and change. When things change, when new evidence comes along, it inhibits the potential, it inhibits a change of practice. So I'm now going to talk to you a little bit about a lot of the things I've learned, certainly in my career in the last few years, to help change the system for the better and help improve patient care. So let's just start about cholesterol. So everybody in the world, pretty much, people are fearful of cholesterol. You've been told that cholesterol is high. If your cholesterol is high, then you're at significant risk of having a heart attack. You could drop dead. It invokes a lot of fear in people, understandably. A lot of the people I see in my consultations, both through the NHS and private practice, a lot of the people are very anxious and come to see me because they've got health anxiety, understandably so, because of a very simple thing around a blood test that shows their cholesterol is high, and they worry about a heart attack, they worry about dying early. But just to try and understand a little bit about where cholesterol emerged, so the Framingham study, which started in the 1940s and 50s, was one of the initial studies that followed up it's now in its third generation of people, 5,000 people in the town of Framingham in the United States. And a lot of risk factors emerged from studying that population to try and see what different aspects of someone's health was going to be most associated with developing heart disease. And high cholesterol emerged from that, which you all know about. But what's interesting, what most people don't know now, is the original Framingham data actually was only able to differentiate significant association with heart disease when people's cholesterol, which would now be considered very, very high. So if you look at the graph, the illustration on the left, you can see that the ideal risk factor should be able to differentiate, someone who has a normal range of a certain measurement in the blood as being, that they're going to be healthy, and an abnormal range means that they're going to get disease. Now, if you look on the right, actually what Framingham showed, there was a huge overlap with cholesterol levels in people who did develop heart disease and people who didn't. And that overlap showed that if your cholesterol was actually very low, less than 3.8 millimoles or less than 150, then the chances of developing heart disease was almost nil or negligible. And on the other extreme, the total cholesterol being over 9.88 millimoles, which actually is considered quite high now, was where you get a very strong association with heart disease. What we know now, obviously, and also at the time, evolved later on, is those people who have very high cholesterols over 10, basically, tend to be people most likely to have something called familial hypercholesterolemia, which affects about 1 in 250 people. And the point I'm making here is the first point is that for most people, your total cholesterol actually will not determine your risk of whether you're going to get heart disease or not. Or if it does, it's a very negligible risk as it increases for most people. Now, what else Framingham threw up is, LDL within the cholesterol profile. LDL is thought to be the so-called bad cholesterol. And what was really interesting is that LDL on its own, unless it was very high above 300 or 7.8 millimoles per liter. And by the way, this is an analysis that was published in 1996 by William Castelli, who's actually one of the original researchers of the Framingham Heart Study. Actually, when they looked at all of the data after many years, they found that LDL was not really very predictive unless it was above 7.8 millimoles. Now, that's huge. That's very high. I rarely see patients with it that high. What I would say now is, and I don't want people to go away, thinking that if their LDL is 6 or 6.5, it's completely fine. It may well be, actually. It may not predict whether they're going to get heart disease or not. I think that cutoff now is probably, in more realistic terms, we found that some people with familial hyperlipidemia actually have LDL, which are a bit lower. So the cutoff for me, which should be, raise red flags in some people, not everyone, is probably 4.9 millimoles. Now, something else I'm going to throw into muddy the waters a little bit here. This data was really only relevant for people up to the age of 60. Okay, so this was particularly relevant for the development of premature heart disease and people dying early from heart disease. And when you get over 60, which we'll come on to in a minute, that is not just negligible. In fact, it's non-existent. What we do use, and you can look this up online as well, it's free, open access, and a lot of people who are listening to this and healthcare professionals will know that you can actually calculate, relatively accurately. It's obviously a little bit of a crude measure. You can calculate your risk of heart attack or stroke over the next 10 years by plugging in different factors. If you Google, later on or whatever, whenever you want to do this, Q risk 3 calculator. This then puts in lots of different things: your age, your blood pressure, do you have diabetes, do you have a family history, and with cholesterol, interestingly, LDL is not used. It's your total cholesterol divided by your HDL, so-called good cholesterol. And that ratio is actually the most predictive from the cholesterol profile in terms of as a risk factor for heart disease. And ideally, you want it to be, the best kind of total cholesterol to HDL ratio from the cholesterol profile itself should really be less than 3, but ideally less than 4. But if it's above 4, if your blood triglycerides are less than 1, then that also suggests a lower risk. Okay, so let's have a little bit of fun here. So we know that from Framingham, there was other published reports, which was interesting, which wasn't well publicized, that once you hit 50 and certainly after 60, what they found is as your cholesterol levels dropped, there was an increase in death rates, overall death rates in the Framingham population, which is interesting. So what we did, myself and some international scientists in 2016, we did a systematic review where we went through all the published data, looking at the association of heart disease with people over 60, the elderly people, in relation to LDL and total cholesterol, but LDL specifically. And we wanted to find out what was the strength of that relationship with LDL cholesterol and development of heart disease if you're over 60. And what was also the strength of that relationship with LDL and all-cause death from other causes. And what we found was, even I was a bit surprised. I thought there would be some association. We found no association. So statistically, there was no association over 60 in people developing heart disease with LDL. And there was an inverse association with all-cause mortality. In other words, statistically, the higher your LDL, if you're over 60, the less likely you are to die. Can you imagine? So I remember after this was published and we got some publicity in the mainstream media through a press release. I remember a patient coming to see me, a lady in her early 60s, into the clinic, and in my NHS clinic, and she walked in and she literally looked terrified. She looked pale, white as a ghost, is a phrase I would use. And I just said, what's wrong? And she said, I'm really worried. My GP's told me my cholesterol is high. And I sat down and I looked at her history and I spoke to her and I said, listen, I said, congratulations. You're probably going to live longer. And she was like, what are you talking about? And I explained it all to her, and she left the consultation fully informed and did not have that fear anymore. And she didn't really need to have that fear. So if we understand that cholesterol, certainly LDL, is not
that important unless it's at least above 4.9 millimoles and certainly, above 7.8. Then it helps us also understand why saturated fat, which has been demonized for several decades as being the primary dietary factor driving buildup of fatty deposits in the heart arteries and causing heart disease, is not the major issue. And I wrote this piece in 2013 in the British Medical Journal, having looked at and analyzed all the data and really put the jigsaw together around cholesterol, saturated fat, statins, which I'll come on to. And that, got a lot of publicity because the BMJ, that it was peer reviewed. They thought it was a really important editorial commentary, and they press released it, and it became a big world news story. I was still actually not a consultant cardiologist at that stage, so it was maybe slightly intimidating for me. But I thought this is a really important message to get out there. So it was a BBC News headlines, it was CNN International, front page of 3 British newspapers. And interestingly, and I wrote that in 2013, we're almost 8 years on from there now. I think if anything, the evidence is actually further substantiated that certainly, unless, again, for the overwhelming majority of people looking at, populations and countries, saturated fat consumption does not really correlate at all with heart disease. And the reason for that, again, on a biological level, remember the total cholesterol to HDL ratio is what's important for cholesterol predicting heart disease, is that actually saturated fat from different foods will raise HDL quite commonly, even if it raises LDL slightly. But even the LDL is broken into 2 particles, type A and type B, and it's actually the type B particles that are more likely to be damaging to the arteries in those people with particularly high LDL levels. So that's another reason why, and when you look at the total cholesterol to HDL ratio, a lot of people who have particularly higher saturated fat diets, the ratio doesn't change. So the cholesterol might go up, their LDL might go up slightly, but the HDL also goes up and even higher than the LDL. So the overall ratio doesn't change very much. And that's another reason why saturated fat on a biological level, certainly from a cholesterol perspective, is unlikely to be a contributory factor to heart disease. The other interesting thing is that there are different saturated fats depending on what kind of foods you eat. So the type of saturated fat you get in coconut oil is different to olive oil, is different to dairy products. And some studies actually suggest that there may be, and this is not definitive cause and effect, but there has been an association with dairy product consumption and the likelihood of the lower likelihood of getting heart disease. And then there's another thing to throw in there, is that this whole kind of reductionist approach to lowering cholesterol by any means possible to get it as low as possible actually can cause harm. And one study, a reanalysis of the Sydney Heart Study, which showed that cardiac patients that replaced butter with a safflower oil containing margarine actually had an increase in death rates despite lowering cholesterol. Now, just going back to that slide early on where we looked at Framingham data, and we showed that Framingham showed that people who had low cholesterol tended to not develop heart disease over time. I think what's important to understand is about 80% of your cholesterol profile, and it will vary from person to person, but in general, about 80% of your cholesterol is actually genetically determined. That's why people, with FH, for example, have genetically very, very high cholesterol. And that also likely applies to people at the lower end. So for whatever reason, people who genetically have lower cholesterol, although they may not live longer, they certainly are much less likely to develop heart disease. And that's, pretty much undisputed. But the question then is, if they've got genetically lower cholesterol, have they also got genetically, lower predisposition to lower blood pressure, which they have, a lot of them do. And they're probably also less likely to develop insulin resistance, which I'm going to discuss about, as being the major risk factor for heart disease. So it may be something else is going on. The second thing to add is just because someone has genetically low cholesterol doesn't mean that us using diet and drugs to lower cholesterol will still get the same benefit. And of course, what we found over now decades of research, affecting thousands and thousands of people from clinical trials, and really in a way an experiment on the population of the world, it hasn't generated a benefit in reducing heart disease, lowering cholesterol in the population. It hasn't actually generated any consistent benefit at all. So I think the evidence is pretty overwhelming that our approach, certainly at the moment, is at best fatally flawed, and at worst is harmful. So Medical Research Council, after my BMJ publication in 2013, my commentary, my opinion piece, which made a lot, caused a lot of, a huge news story and got people thinking around this a little bit better, which I think was a good thing, at least encouraged the debate. Actually then did a reanalysis of what we call randomized control trials and observational studies. And interestingly, you then concluded, with the British Heart Foundation, this also got publicized at the time, that current evidence does not support guidelines that restrict the consumption of saturated fats and encourage the consumption of polyunsaturated fats in order to prevent heart disease. And they found something really interesting as well, is that one interesting finding was that the consumption of one particular fatty acid, saturated fat found in dairy products called margaric acid, was associated with significantly reducing the risk of heart disease, which is just extraordinary. In particular, this was also then repeated in a study in the Lancet that found that actually, if you compare people who have very low levels of saturated fat consumption, less than 5% of calories, versus people that had about 13% of saturated fat as part of their total calorie intake, there was much less strokes in people who had a higher consumption of saturated fat as well. So what the take-home message is, to cut through all of this data, really, I think this is, this focusing on one particular nutrient has been misguided and wrong. And actually, what many people have done, what the food industry did is, and they then started promoting all these low saturated fat food products that were very high in starch and sugar, and that actually itself now has been shown to be associated with increasing the risk of type 2 diabetes. And what we should really be focusing on is just healthy diets and healthy dietary patterns in keeping with real food. One of my, somebody I admire greatly, professor of cardiology, editor of JAMA Internal Medicine, based at University of California, San Francisco, is Professor Rita Redberg, very credible cardiologist, researcher. And what she says is that, focusing on cholesterol lowering has been counterproductive. He actually said this in a documentary that was, that came out in Australia, that was done by a science journalist over there. And she says, who cares about cholesterol lowering if it doesn't actually translate into a benefit for patients? So for me, you have to think about actually, what is the purpose of lowering cholesterol? How are you lowering cholesterol? And what is the evidence that it's going to benefit you based upon published data? So let's talk briefly about statins. So, this is a drug that is estimated to be prescribed to almost 1 billion people around the world, probably one of the most lucrative drugs, if not the most lucrative drug in the history of medicine. Total sales, from revenues from sales of statins are estimated to be close to about $3 trillion US. So this is a very, very widely prescribed, lucrative drug. But let's actually just ask ourselves, what are the true benefits for individuals? So this publication, which was a reanalysis of already published data, which I must tell you is, pharmaceutical industry sponsored data, but looking at that data and breaking it down, that data that's already published, not new data, to actually look at, for people at low risk of heart disease, so people that have a less than 10% risk of having heart disease, certainly, over the next 5 to 10 years, what was the benefits of statins based upon published literature? And what was found is that it was about 1 in 140 people were prevented from having a non-fatal heart attack or stroke. No one had a prolongation of life, so there was no extension in life expectancy. And the side effect issue, which still remains controversial, is, and it varies depending on what literature you look at. The published, pharmaceutical industry-sponsored research suggests that the side effects are probably less than 1%, but actually, real-world data suggests it's certainly closer to 20%. My view is probably much higher than that. But just, I think, to reiterate here, these are not, these are disabling side effects that interfere with quality of life. In most cases, they are reversible. There's something that can be reversed within a few weeks, and this is what I see in my patients. With either reducing the dose or stopping the statin. And again, this is something that if you're concerned about side effects, which most commonly are things like fatigue, but they can cause stomach upset, they can affect people's memory. I've seen lots of different types of side effects. In most, over a majority of cases, these side effects are reversible. So it's about quality of life, but it's also about knowing what the true benefit is. And I think patients need to know that. For people with heart disease, people who've had heart attacks, or significant heart disease, okay, so they've got established heart disease, as in, they've got angina, for example, that level of benefit is about 1 in 83 for mortality. So that is, you take a statin, you've had a heart attack or you've got significant heart disease, you take a statin religiously every day for 5 years, because that's how long the trials normally last, clinical trial data lasts, the data that we interpret the benefits from, is about 1 in 83 in terms of saving your life or delaying your death, and about 1 in 39 in preventing a heart attack. Now, that information, I think, is very important to share with patients. It's not part of routine practice, but it's considered actually a more honest, transparent, and more ethical way of helping patients make informed decisions about statins. And the data that's there in terms of looking at when patients are presented with this kind of information, how many of them will take a statin, how many won't. Interestingly, about a third of patients with heart disease, with very high risk, probably wouldn't take the statin. The people at low risk, most of them wouldn't. Now, it's really interesting because a lot of people who are prescribed statins and are taking them aren't given this information, and it probably would change the decision-making process. And that's something I think we need to, think about and advocate for. And, that's something that even the Academy of Medical Oncologists have said that, we should be doing routinely with patients. So I'm going to just a little bit of a quick maths lesson here about how we've got to this situation where, benefits of drugs are grossly exaggerated and harms are minimized. So different ways of presenting a benefit, you can use something called relative risk or absolute risk, or numbers needed to treat. So if you communicate information in relative risks, then it will exaggerate the benefits, both to doctors and to patients, okay, of medical interventions. So I'm just going to give you an example here. If you, for example, in people with, if you look at clinical trial data in patients with type 2 diabetes who are prescribed atorvastatin, over a 4-year period, just looking at stroke reduction, what we found, what the trial data found is there was a 48% relative risk reduction having a stroke over 4 years. Now, what did that actually mean? So if you take people in the trial, in the placebo control trial, so given a dummy pill versus taking a statin, if you weren't taking the statin and you followed 1,000 people, okay, over a 4-year period, 28 of them who took the dummy pill suffered a stroke, okay? And if you took the statin, that 28 number then was reduced to 13. So what does that mean? Well, you've actually reduced that risk to actually a very small number. You've reduced that risk to 1.3%, which meant that for an individual, the reduction in stroke is actually just to reiterate this. So 13 people out of 1,000 that took the statin were prevented from having a stroke. So that's 1.3%. Yeah, 13 over 1,000 is 1.3%. But for an individual, the way I explain it to patients is that if you take this drug religiously for the next 4 years, in a type 2 diabetic, based upon industry-sponsored data, so this is probably best case scenario because they also select patients that are less likely to get side effects. So if you're not going to get side effects and you take this drug religiously for 4 years, there is a 1 in 77 chance it will prevent you having a stroke. That also means that 76 out of 77 are not going to get any benefit. Now, that is not something that we routinely discuss in clinical practice. And this has also been made worse by mismatched framing in medical journals. So what happens is if a treatment reduces the risk of developing disease from 10 in 1,000 to 7 in 1,000, okay, but increases the harm from 7 to 10, so it's the same thing, the article will report a relative risk reduction of 30%. Okay, so 3 out of 10 is 30% relative risk reduction, but the harms of 3 in 1,000 of 0. So it's exactly the same, but they're presenting it differently in terms of benefit and harms. And actually, an analysis showed that 1 out of 3 of all articles published in The Lancet, the BMJ and JAMA between 2004 and 2006, so it's just a random sample taken, actually use mismatched framing. Often these are studies published by the drug industry, which is pretty extraordinary. And of course, what's going to happen there is it's going to exaggerate the benefits of a medicine or a treatment or an operation and minimize the harms. So it's going to then favor that bias in terms of treating people. And don't just take my word for it. You can look this up. Actually, in 2009, so we're talking about 12, almost 12 years ago now, Gerd Gigerenzer, considered the world leading researcher on health literacy, he actually published, he wrote in a World Health Organization bulletin that it's an ethical imperative that every doctor and patient understand the difference between absolute and relative risks to protect patients against unnecessary anxiety and manipulation. And yet we have not got this change within clinical practice yet, routinely. I do this all the time with my patients. I do this through NHS, I do it through private practice. I make sure my patient is fully informed, and patients want this information to make those informed decisions for so many reasons. it's not just about understanding the drug they're taking and what it's doing for them, but it's also about, okay, it's not just about the drug. There are so many other things that you can do, which we're going to talk about now, when it comes to preventing a risk for heart disease. And many patients, unfortunately, traditionally have thought that they can take a statin, they can lower their cholesterol, and it means they can eat what they like. And I was increasingly seeing more and more obese people coming to me who had great low cholesterol levels on a statin, which, by the way, was not going to prolong their life because they were actually low risk. They didn't have significant heart disease, and yet they were going around thinking it was a license to, go to, fast food. I won't name any particular chains. It's not fair to single out any particular fast food chain, but you know what I'm talking about. And that again is just really just bad science. In my view, it's far from the optimal way of practicing medicine, and it's not deliberate. This is just something that we're not conditioned or trained to do in medical school. Okay, let's just shift a little bit onto COVID-19 now. So, this is something I've been looking at and analyzing, and I've been writing about through both through a medical journal and also through mainstream media articles since we went into the first lockdown, March 23rd last year. And what became clear, and has also been confirmed now with all the data we've got, is that there was a clear association between excess body fat with obesity and people having a worse outcome from COVID-19. And this is not new. It's actually well known in the medical literature that having excess body fat, sets you up for what we call a chronic inflammatory state. So your body is really in a constant sort of fight against the fact that you've got too much body fat in your system. And what's going on here is that two things happen: is that the immune system is then not optimized, because if you imagine your immune system is trying to deal with the excess body fat, if you like, or what's generated from the excess body fat. But also people who unfortunately sadly die from COVID-19, a lot of those people have what we call a cytokine storm. They have an exaggerated immune response as well, that then results in them dying from respiratory failure and having a worse outcome from pneumonia. So I think what people should understand in a very basic term is that excess body fat is a risk factor for a suboptimal immune system. And we know this from flu data as well. And it's also something that happens as you get older generally. Now, it's not inevitable, but in general, as you get older, you become more frail, your immune system is not as robust. And certainly the biggest risk factor on its own from death from COVID-19 is age. And depending on what data you look at, if you're over 60, you're 23 times more likely to die from COVID than if you're under 60. I think just to give perspective here, if you're under 50, for example, then your risk of dying from COVID is still very small. It's certainly higher than the flu, but it's quite small. And certainly, children almost have no risk. It's a very, very, very low risk. But the elderly, if you're over 80, we're getting up to figures of almost 7 to 8 to 10%, which is very, very high. So it depends on your age is extremely important. But as you've probably been hearing, we in the UK and certainly USA, a lot of the countries that have had the worst outcomes from COVID are also the countries that have the worst levels of chronic disease, the highest levels of obesity. And then at the root of all of that is lifestyle. We look at diabetes. So diabetes is another big risk factor. I'll just explain that briefly. So we've talked about excess body fat being a risk factor for dying from COVID-19, but also your blood glucose. So studies that looked at people admitted to hospital with COVID-19 with type 2 diabetes, and the ones that had the worst blood glucose on admission, in keeping with worst blood glucose control. Although one caveat I must mention is that also a stress response will raise your blood glucose. So it could also potentially be a degree of the severity of the illness on admission. But I think even if you account for that, worse blood glucose control itself actually worsens outcomes from infection in general, because viruses and bacteria do thrive off high blood glucose. So there was a 10-fold increased risk in death in those, particularly in type 2 diabetics, who had worse blood glucose control compared to those who had very good glucose control. So that's a really important concept to understand. And if you're breaking it down, understanding obviously that's small, I don't want to mislead people here with statistics again, but if we accept, let's just say the overall death rate from COVID-19, if you take all ages together, is probably in the region of about 0.6 to 0.7%. you know, looking at various things, risk factors that people have. You know, being obese basically means it doubles your risk of being hospitalized and increases your risk of death by about 1.5 to 2 times. But metabolic syndrome is actually much more important, which I'm going to explain. And obviously the title of the talk is about optimizing metabolic health. And this is what we should really be focusing on, not just about infection and COVID-19, but about heart disease, probably in relation to Alzheimer's, cancer, and dementia as well. But metabolic syndrome is actually much more important than obesity in terms of being a risk factor for death from COVID-19. Okay, let's define it now. So in simple terms, metabolic health really is determined by you know, the level of body fat for you, body fat percentage, that then starts to increase your risk of developing a number of conditions such as blood pressure, type 2 diabetes, and a normal cholesterol profile, which is characterized by high blood triglycerides and low HDL. So this is actually what we should really be doing, I believe, throughout the whole of you know, medical practice, both in primary care and in secondary care. And it's not expensive to know most of these tests. You've got basically one or two blood tests to look at, you know, your HbA1c, which is your level of your blood glucose on average. You do not want to be pre-diabetic, ideally, so have it less than 5.7%. The blood pressure, ideal blood pressure should be less than 120/80. Between 120/80 to up to 140/90 is considered now pre-hypertension, and then over 140/90 is when you have mild hypertension. Then, you know, as your blood pressure goes up, the severity and risk of stroke increases as well, with blood pressure that increases after that level. If you notice here, neither LDL nor BMI is part of this body mass index, because it's not very helpful or reliable. Body mass index, which is calculated by dividing your weight in kilograms by your height in meters squared, is very crude. It doesn't take into consideration your ethnicity, your muscle mass, your age, your sex. Now, when it comes to the development of heart disease, actually metabolic syndrome is the most predictive of heart attacks. So 2/3 of people now admitted with heart attacks will have metabolic syndrome, which basically means you've got 3 of those in the abnormal range, 3 of those 5 in the abnormal range. And the level in the population is so dire in terms of people baseline health now that only 1 in 8 Americans actually have all of those within the normal range as adults. And even only 1 in 4 people, young people between the ages of 20 and 40, have all of those within the normal range. And the reason I get a little bit wound up about people talking about obesity and so-called healthy weight is it uses BMI as a cutoff. But actually, depending on your ethnicity, up to 40% of people with a normal BMI will actually have suboptimal metabolic health because of excess body fat, usually around the abdomen. And this affects, you know, 43.6% of South Asians. And it still affects Caucasians as well, about 20% of Caucasians. So we're missing something here. We're probably missing a huge cohort of people who may be being, you know, unwittingly told by their doctor that you've got a healthy weight, when in fact they've got too much body fat that's going to cause them a problem. And therefore they're not acting upon it, and therefore they're going around at very high risk. Vitamin D deficiency has been very strongly correlated with worse outcomes from COVID-19. And in fact, there's also data suggesting that you are more likely to catch COVID-19 if you're vitamin D deficient. And the cutoff is around 30 micrograms per, you know, you know, in terms of the severity or risk of death. And people who had very severe vitamin D deficiency, that, you know, risk of death is more than tenfold from COVID-19, because vitamin D itself is a pro-hormone. It has so many roles in the body, which is also, it's extremely important in the immune system. And there's lots of research and data on that now. It's again something that we've not really thought about until COVID-19 came along. We also know that it's very strongly associated with heart disease, about 5 to 6-fold increased risk of developing heart disease if you've got severe vitamin D deficiency. And it's also probably a big factor to explain why people who have darker skin, people from South Asian and sort of Afro-Caribbean backgrounds, also were more likely to develop complications or die from COVID-19. Because in this country, in the UK, and this is pretty shocking, the overwhelming majority of South Asians, from cross-sectional data going back many years, are either deficient or severely deficient in vitamin D. So most people actually are deficient. They don't know it. It's not something that's routinely measured. I think the case I would make is it's very cheap to just take supplements. There's very low risk of toxicity. The Public Health England now, they do some good stuff. do recommend that people certainly through the winter months should take 10 micrograms a day. And I think that really everybody should probably be taking vitamin D because it does support the immune system as well. So we talk about metabolic syndrome, metabolic health, excess body fat really creates this vicious cycle of chronic inflammation and insulin resistance. And it's now being linked through high insulin to development of many conditions, not just heart disease. We know type 2 diabetes develops because of insulin resistance initially, and probably also cancer. Certainly Alzheimer's disease, some people have said that we should rename it type 3 diabetes because the same biological mechanisms of development type 2 diabetes are there for Alzheimer's as well. Something very simple everybody can do crudely to try and see whether what their metabolic health likely is just look at their waist to height ratio. So you want your waist circumference to be less than your less than half of your height. Okay, that's ideally what you want to be aiming for. But of course, the other things are important. Blood pressure, of course, measuring your average blood glucose, etc., and looking at triglycerides and HDL. So I was very convinced by the data that was out there. I know as someone that's been practicing with patients that in terms of metabolic syndrome can be reversed. I wrote a book about it. My first book, Piopi Diet, is an up to 50% of patients, certainly with obesity, metabolic syndrome can be reversed within 28 days of just changing diet. So when all of this, started to emerge around COVID-19 and the messaging about stay at home, protect the NHS and save lives, for me, I think one of the most important parts of the public health messaging that was missing was actually to tell people, listen, what you eat right now may make the difference between life and death of you getting COVID-19. And it's not just about the fact you can improve your metabolic health very quickly within a few weeks of changing diet. And also, of course, the vitamin D thing was really crucial. And that, again, I don't think there was a strong enough message on that. It's also about the blood glucose. So if you're pre-diabetic, there was also other data that showed if you were, even if you were non-diabetic, the admission blood glucose also predicted your risk of death in non-diabetics to hospital with COVID-19. So, theoretically, if you're in the wrong place at the wrong time, you get COVID-19, eating junk food, eating Krispy Kreme donut, eating kind of foods that are very, starchy or very refined carbohydrate, sugary foods, at the time that you get COVID could actually make the difference. It could be the deciding factor between life and death. So, anyway, I wrote this article last year, just after Boris Johnson obviously got out of hospital. And again, this was not discussed. And I was the first person to really make that case, saying that, we need to talk about weight. And this is being missed. It became a front page featured article in the Daily Telegraph. I then went on Good Morning Britain and BBC News, made that case. I suggested publicly at that point that it was likely Boris Johnson got sick, particularly sick because of his weight. No one had mentioned it at this point. And then it became a story in itself in the Times. And I think, I was saying it from the perspective of not fat shaming. For me, the root cause of this whole problem is really food industry influencing dietary guidelines, influencing the food environment, corrupting information, if you like, for the purposes of profit. That's at the root of this problem. This isn't about individual personal choice so much as the environment. But it was my duty. I felt it was my duty as a doctor to observe, knowing Boris had been public about the fact, before even he got sick, that he was significantly overweight, obese. And I said that it is probably likely, I don't know his full history, but it's probably likely that played a factor. And then, he later on did come out and admit and started, and I wrote this book in a very short space of time to get it out to change policymakers. I had an interaction with Matt Hancock, the health secretary, who asked me for advice to advise him on the link between obesity and COVID-19. I told him it was beyond obesity, Matt. I said, this is about metabolic health. And we need to introduce policies to help people make healthier choices in terms of what they eat. Again, let's not forget this when we look at the global burden of disease in general, even pre-COVID. Poor diet now contributes to more disease, chronic disease, and death combined than physical inactivity, smoking, and alcohol. Ultra processed foods is probably the biggest factor that's driving this poor diet. It's now half of what we eat in the UK. What I tell my patients, what I'm telling you, a very nice, simple way of understanding it is if it comes out of a packet, this isn't just about your junk food, it's your packaged foods, it's your packaged bread, brown bread in the supermarket. If it comes out of a packet, it has 5 or more ingredients, so usually starch, sugar, unhealthy oils, and additives and preservatives, then it's ultra processed and you shouldn't eat it. You should certainly not, or certainly minimize it as much as you can. And what ultra-processed food does, and there are some small studies looking at ultra-processed food and drink, is even in the short term, and junk food in particular, increases markers of inflammation in the blood, which we also know is not good for long-term health, and certainly probably has an impact on the immune system in the short term as well. David Unwin is a good friend and colleague of mine, pioneering GP. He's done a lot of great work, publicizing that in his practice. He's been doing this for many years. Is he puts people with type 2 diabetes on a low carbohydrate diet. And we can see just from here, but there's also other published data that confirms this, that you can improve all of those markers of the metabolic syndrome. And he's managed to send many of his patients with type 2 diabetes remission, almost 50% of them, which is pretty extraordinary. But it's also, I've not published data on my own personal, I've done some anecdotal case reports, for example, but certainly I'm seeing that with my patients as well. Something I published a few years ago when I became more enlightened is that not just about the whole risk factors and chronic disease, but there is some data showing that hard outcomes, as in actually lowering, stroke rates, heart attack rates, death rates, actually, from data that we've got available, is likely to start happening within weeks to months of just changing diet as well. I'm a big advocate of the Mediterranean diet. I still think that the best evidence we have, data we have available, is a diet that has the base on a traditional Mediterranean diet on specific foods like, extra virgin olive oil, oily fish, a mixture of whole fruit and vegetables, nuts and seeds. I think the best data we have, certainly in terms of the anti-inflammatory components of food, come from those particular types of food. And also, as we know, refined carbs and sugar in particular worsen insulin resistance. It's probably the best dietary pattern to improve people's health in the short and long term. Is probably going to be one that's based upon a low carb Mediterranean style diet. I'm not saying it's the only diet. I think that when I put the information together, and I'm very happy to be challenged on this, or data may emerge that suggests something different, I still think at the moment that's the best data we have. And we're covering everything here from gut microbiome to fiber, to improving cholesterol profile, to be anti-inflammatory. It's all going to come down from a base of a Mediterranean style diet that is low in sugar and refined carbohydrates. Another publication I co-authored was, lead author was Isabella Cooper, who's a nutritionist and very intelligent, very smart academic as well. Essentially, what we also have discovered, certainly looking through the literature, is that before you even have high glucose, you have high insulin, and even that can be present for even 2 decades before people develop type 2 diabetes. So I think if we're going to go even beyond those markers of metabolic syndrome, at the root of all of it is probably chronically high insulin, which is influenced by a number of factors, which include the type of foods you eat. It includes the amount of sleep you get, it includes how much exercise you do, and it includes stress as well. So all of these things can influence your basal insulin levels, which is a fat storing hormone, and also development of insulin resistance, your cells becoming resistant to the effects of insulin over time. But what's also interesting is that even if you don't have any chronic disease, there are some studies that have shown that even if you keep glucose normal and you raise insulin artificially, then it actually affects your clotting in an adverse way. So again, very simple terms, you're more likely to clot by raising insulin as well. And I think that this is interesting because even people who with type 1 diabetes who have good glucose control have shorter lifespans and sometimes up to 10 years than the average person, despite lowering their glucose over a number of years. So the message here, and I think something we need to think about, is for the type 1 diabetics as well, we need to be making sure that they are ideally also eating foods that are not going to be require them to take higher doses of insulin. Because insulin itself also is pro-atherogenic. It does actually contribute in a small but significant way to development of heart disease too. It's also pro-inflammatory. So bottom line is, let's try and think about, dietary patterns and lifestyles that are going to minimize, having high insulin and having high blood glucose as well. Okay, so just to conclude before we get into the Q&A, and I've overrun a bit here, we're almost probably 45, 50 minutes in, but that's fine. Plenty of time for the Q&A. So poor metabolic health also equals poor immune health. Obesity, unfortunately, is still very misguided. We're not focusing on really it's just the tip of the diet-related disease iceberg. Most people who develop diet-related disease are not obese. They have either normal body mass index or are overweight. COVID-19 mortality is again related to diet, because the driving factor behind the excess weight is related to diet. The good positive news is that you can improve these metabolic health markers. It's never too late, by just dietary changes alone. And I'm not just advocating for dietary changes alone, but the data we have shows that, you know, if you look at all the different lifestyle factors, certainly in the short term, dietary change is the only one that's been proven to reverse metabolic syndrome within a few weeks. Exercise alone will not do that. Reducing stress has loads of benefits mentally and physically, but in terms of those markers, it will not do that. So it has to be, the primary approach has to be dietary change. And of course, the other things are really important to add on to that, but that's what we should be focusing on primarily. And of course, our healthcare system is not going to be fixed until we improve the food of the nation, what people are eating in their day-to-day routine, what they eat at home, what they eat when they go out, what they eat in hospitals and schools. All of that needs to be resolved. Okay, thank you very much, and I look forward to now a discussion in the Q&A.
Thank you, Aseem. We've had quite a few questions come in, and I've got a stack of questions here as well. So I do apologise to everyone that sent in questions even prior to the event today. We're not going to be able to get through all of them, sadly. So I'm going to do some off the live feed. So we have a question from Claire Phone on does the menopause affect cholesterol? Can it have an effect on the ratios, specifically HDL, LDL? It says, do studies separate out men and women, as we have very different influences on our health? So we had a couple of questions on the menopause and cholesterol. There's another one as well. Yeah, does the menopause...
I'm not familiar with any. I mean, it may have some slight changes. I don't think, as far as I'm aware, I'm not aware of any big dramatic effects on the cholesterol profile. In terms of women, interestingly, actually, there is some published data showing that certainly LDL and cholesterol is less predictive, absolutely, of heart disease than in men. So I think that's, you know, being male itself also is a risk factor. Cholesterol, as I've already illustrated, and I will illustrate further in the next few months, and the next book I'm writing, is, you know, I think we need to have a much more nuanced approach to cholesterol. It shouldn't be the primary focus of consultations around reducing the risk of cardiovascular disease. And as I've already illustrated as well, statins have a very, very small effect at best from the clinical trial data that's published. So, you know, I think the cholesterol focus, I think people should stop being overly obsessed with their cholesterol.
Okay. Got a question on COVID-19 infection. Can the COVID-19 infection lower your vitamin D levels as well? So not only did you have low levels, we're not sure. Did you have low levels? So when you
that I'm aware of, don't know the answer to that. I think what we do know is if you have metabolic health, poor metabolic health or excess body fat, that sequesters or can draw in vitamin D from the blood. There's also some data that high sugar diets stop the effectiveness of vitamin D.
Okay.
So you know, some of this association of vitamin D and poor outcomes could also be because of underlying excess body fat, obesity, poor metabolic health, that actually then lowers the vitamin D as well. I'm not aware that you know, COVID-19 will you know, the data may change, or there may be data out there that I've not seen, but I've not seen anything that suggests that COVID-19 infection itself dramatically lowers vitamin D. And I think that what I would say is, because we also know of this strong association, certainly with ethnic minority groups with darker skin, who interestingly need more sunlight than people with lighter skin to generate the same amount of vitamin D, it's likely that even if there is an effect on vitamin D from COVID-19, it's probably very slight. So the baseline vitamin D is probably already very low in a lot of the people that get worse outcomes from infection in COVID-19.
Okay. Here's a big one. Is coronary artery calcification reversible?
Yes. Reversible in the sense that there are some small clinical studies that show that people can reduce their coronary calcium scores. Trying to understand the best mechanism for this is still debated, but it again comes down to a combination of a prudent, of a healthy diet, moderate exercise, stress reduction. These are probably the most important things that people can do. There's a cardiologist in the United States called William Davis who's published, a case series of his patients, and he's shown, if I'm not wrong, I think about 44% of his patients have managed to lower their coronary calcium scores through a variety of approaches, from dietary approaches. You can look that up. There's a friend and colleague of mine, Ross Walker, in Australia, in Sydney, and I've spoken to him, and he's informed me many of his patients have managed to lower their calcium scores just from changing their lifestyle, their diet in particular.
Okay, we've got one here on statins. What is the explanation for the small beneficial effect of statins? In other words, lowering oxidized LDL, or the more pleiotropic anti-inflammatory effects?
Yeah.
Also goes on to say, do you recommend low carb, high fat diet alongside coenzyme Q10, vitamin K2 to prevent side effects from statins?
Okay, Richard. So let's just answer that. Yeah, there's a lot of different questions. So first question is, and I published this in the BMJ article in 2013.
Yeah.
But there is first of all, if you look at all of the randomized control trial data on lowering LDL from drugs, so the drugs have a much more dramatic effect, because some cynics could argue that the reason that changes of diet don't show any benefit in reducing heart attack, strokes, death, for example, from lowering LDL is because they didn't lower LDL enough. And you need to lower LDL significantly to see a benefit. So this is something actually myself, a physician cardiologist called Robert Debruff in University of New Mexico in the United States, and Michel de Logeril, who's a cardiologist in France. We actually did a systematic review and published in BMJ Evidence-Based Medicine last year. You can look this up. And what we did is we looked at all of the drug trials that lowered LDL, including statin trials, and we found there was no consistent or reliable correlation with the lower the LDL and reduction in heart attack, strokes, for example, and death. That's the first thing. There was a slight correlation, but it wasn't particularly strong, certainly not what people are being told. And it was not, there was no relationship with the degree of LDL lowering and reducing the risk of heart attack. So the conclusion, and this supports what I'd written about several years ago, and we know that this actually is one of the mechanisms of statins benefit, is it is much more likely that the small benefit from statins that exists, certainly in people with heart disease, is probably through some anti-inflammatory and antithrombotic, as in, reducing the risk of a plaque rupturing thrombus effect, not throughout lowering LDL.
Yes, so they talk about the pleiotropic effects.
Yeah, and the second part of the question, Richard?
Well, do you recommend low carb, high fat diet alongside coenzyme Q10, vitamin K2 to prevent side effects from statins?
Yeah, so I mean, the coenzyme Q10, a lot of my patients come back. So remember, for me, it's about shared decision making with my patients. My patients actually inform me a lot, and I learn from them, their experiences and what they tell me. And a lot of patients find that certainly in terms of the muscle ache side effects of statins, the coenzyme Q10 can be helpful, right? And as far as I'm aware, there's no harm from it. So if a patient wants to take coenzyme Q10, that's absolutely fine for helping their symptoms. In terms of vitamin K2, vitamin D, for me, if you can get these vitamins from your diet, I don't personally think there's any strong evidence of benefit for the majority of supplements for people that can absorb all these nutrients from diet. Maybe, certainly with the exception of vitamin D, which I think most people need to supplement if you're not getting enough of it from sunlight. K2, I think, a very mixed picture out there. There was initial suggestion vitamin K2 can help reverse or reduce coronary calcium scores. It may well do that. I'm not convinced by it. And I think people need to be a bit careful with K2 because it can interact with other drugs and affect clotting as well. So I don't really have a very strong opinion on K2, but certainly vitamin D, if you're deficient, it's likely that a supplement would help. And remember that vitamin D deficiency is strongly associated with the development of heart disease. But if you can get enough vitamin D from sunshine and from dietary approaches, then you don't really need a supplement.
Okay, we've had quite a lot of questions on vitamin D. So I think you probably covered that. One of the questions I've got here that's been handed in to me before, that I printed off before the event, was from David in Brighton. He wants to know about alcohol. So there is some evidence, and I don't know what your thoughts are, that that drinking red wine regularly in small amounts is actually cardioprotective. His concern is, do I need to be, what effect will larger amounts of alcohol have on the heart? Apart from the obvious ones like raising blood pressure, what is there a greater risk from drinking more than the recommended units of red wine?
Yeah, so it's going to be all very individual based. I think in general, and I've looked at this data, there may well be some benefits of red wine consumption at moderate levels, 14 to 21 units a week, probably for a male. But actually, once you get above those, even 14 to 21 units, there's a slightly increased risk, and it increases the more you consume, certainly with cancer. And that's pretty clear data. In terms of the heart, yeah, so I would see excessive alcohol consumption. We're talking about getting into the levels, usually when it becomes toxic to the heart is much higher levels, certainly above 30, often above 50 units a week. And I've seen some patients that develop something called alcoholic cardiomyopathy, where their actual, and I'm sure you've probably seen some patients in cardiac rehab as well, Richard, is where the actual alcohol it's toxic to the heart muscle. And that usually can start at above 50 units a week, okay, over many, many years. The good news is when people get it, but isn't an excuse to do it, is it often is reversible when people give up alcohol. Then the heart muscle pump function gets better. So it can actually affect the left ventricle, and it can affect the ability of the heart to pump properly. And that's another reason not to drink too much. But I think excess alcohol is a big problem in this country. And I think that, there is a nuance here that certainly when you look at the association of red wine consumption and maybe reducing risk of heart disease, it comes from obviously those cultures where people drink with their food. It's not the typical British, preloading, binge drinking, and the evidence suggests there's probably some synergistic effect of drinking the red wine with the vegetables or with the oily fish together, and those polyphenols, anti-inflammatory components, probably have a kind of combined effect through those dietary patterns with the red wine. That's most likely, from what I've studied and looked at and researched, where the benefits from red wine come.
Okay.
So basically, if you're going to drink red wine, you can drink a large glass if you want every day, whatever, if you're otherwise fine. Have it with food. That's the way to drink it, Mediterranean style.
Okay, I hope that answers David's question. Thank you, Aseem. We've got a question here from Di Lloyd Jones. As insulin resistance, which you've talked about quite a lot, is all important, why is it never offered by the NHS? Is there an available or an affordable blood test to check whether or not you're insulin resistant?
Yeah, so okay, the first thing to say is that, I talked about at the beginning, 50% of what you learn in medical school turn out to be either outdated or dead wrong. So the conventional medical practice hasn't caught up, first and foremost. I think that we always think about, when we think about doing a test, we also think about what's really important in medicine, and what I learned in medical school, and I still very much adhere to, is before ordering any investigation or test, you've got to think about how is it going to change management of the patient. Now, some people think, okay, well, I might need the test to then change the, measure that what I'm doing. And I see this certainly in my private practice a bit more. Some patients want to look at a marker to help them feel confident that what they're doing is working. And I understand that, and I get that. When it comes to insulin resistance and insulin, I think unless there's very strong evidence to show there's an extra benefit, I think that we can just do those simple things. First and foremost is, what is your blood pressure? What is your HbA1c, triglycerides, HDL, waist circumference? And if all of those are in normal range, it's likely, and you also know from yourself in terms of what you're eating, it's likely that you're probably okay, or your insulin levels are not going to be sky high, because usually one of those things will be off to start with if your insulin levels are high. So that's why I think it's not at the moment absolutely necessary. Things may change, but it's not, again, part of routine NHS, management and checking. And the other thing is, once people know, that from studies that are there that high insulin or whatever else is a risk factor for all these things. We know the solution to it. We know what to do. So instead of people, you know, I think I probably got my fasting insulin done many years ago, and I've not rechecked it. And it was, you know, probably borderline, you know, going to a slightly high level, you know, but I just changed my lifestyle or whatever else. All my metabolic health markers are excellent, you know, thank God for now. But I don't need to recheck it, really, to be honest, because I'm doing my best to adhere to all those lifestyle factors that I know are going to be important. So, you know, it's going to vary from individual to individual, but I don't think we need to be checking fasting insulin in everybody. We've got enough data to show that it's important, but we know what to do about it.
Great, thank you.
I hope that makes sense.
Yep, but absolutely tons of questions here. One from Neil Walker here wants to, how can one improve one's HDL levels? Because we talked about the LDL is the bad.
I wouldn't focus on, so this is another, I think, we could go down the same problem that we had with LDL, okay? Yeah. So the HDL and the triglycerides are a surrogate, they're a marker of insulin resistance. If we focus on insulin resistance, and I'll talk to you about that again and repeat what needs to be done about that. And this is what I see with my patients. The HDL often, and it's going to vary from individual to individual, will increase and the triglycerides will come down. You cut out the refined carbs and the sugar, your HDL invariably will increase to different degrees and your triglycerides will come down. The other, other side of this coin is inflammation as well. So the two big issues are chronic inflammation and insulin resistance. They often overlap, but the approach to managing them both is the same. It's about getting on top of the diet. It's about making sure you're doing at least 30 minutes of moderate physical activity 5 times a week if you can.
Yep.
It's about making sure you're getting good quality sleep and you've got your stress levels in check. And once you've got to that stage, the question about, okay, well, people, should I take a drug to raise HDL? Should I take a drug to lower triglycerides? There isn't really any consistent evidence of benefit from doing that at all from the drugs. In fact, there's actually more benefit from statins and lowering LDL from any of the other drugs that affected triglycerides and HDL. And that's because these are probably markers of something else. So you've got to go to the root cause of the problems of HDL and triglycerides, which is insulin resistance. And if you sort out the insulin resistance, the metabolic health markers get better. And the best way to sort out insulin resistance is through lifestyle approaches. There's no drug that's been effective to help insulin resistance. And you've got to also ask patients, is that what you want to do? Because every drug comes with side effects. So is there something else I can do instead? So I would not be obsessed about increasing HDL. But interestingly, those things themselves, often the exercise, the diet, reducing sugar, even red wine to some degree can raise HDL. Coconut oil can raise HDL, but is there any evidence that eating lots of coconut oil is going to help you prevent getting heart disease? No, there isn't. It can be part of a healthy diet. I've advocated on this. I even took on a professor in Germany who came out and said coconut oil poison is going to be a heart attack. I said, well, there's no evidence of benefit from that at all. There's no evidence of any truth in that. So I've been very strong about that. But would I tell people that in a way to combat heart disease, they should be having lots of coconut oil to raise HDL? No, I wouldn't do that either. No.
Okay, great. Thank you. I've got one here from Jenny Packwood. Can cardiac cells happily function long-term using ketones for energy when following a low-carb, healthy ketogenic diet?
There's no evidence of any long-term harm that I have seen or aware of from a ketogenic diet affecting the heart adversely. If people want to read a really interesting case study, which is open access, so what's the name of that audience member?
Jenny Packwood.
Jenny. So okay. Jenny and other people, one of the most fascinating cases I came across, which I wrote up because it's very interesting, is about a patient of mine, and he gave permission for this, and it's on the internet anyway, called Tony Royal. If you look up Tony Royal, if you look up an article I wrote, or you can look up Tony Royal, Daily Express Aseem Malhotra, and it's ROYLE. His story was a heart attack patient in his 50s, former international airline pilot, overweight a little bit, conventional diet, running marathons, had a heart attack, started looking at research and literature, could no longer fly again because you can't fly if you have a heart attack. And then now, he's a background in maths and physics, very intelligent, smart guy, understands data. Long story short, he went on a ketogenic diet. He's still on it several years ago. He's doing very well. He stopped all his medications out of his own personal choice with discussion with his doctor after having the heart attack. And he is now breaking his own records running ultramarathons. His heart's in great shape. And that's 4 years on, and he is obsessively in ketosis. So if you look up an article called Ignorance is Not Bliss, why we need more informed patients, better doctors and informed patients, something along those lines, published in the Pharmaceutical Journal. It's open access. You can read the case study I wrote up with the former chair of the Medical Royal Colleges as his case study and what we should really be doing in medicine, that covers actually many of these topics I've discussed in this talk. And that was well publicized, and it was accepted and published, and we've got a lot of interest. And that really is a way, a kind of template that covers lifestyle, shared decision making, statins, and actually this chap is on a ketogenic diet, Mediterranean style ketogenic diet.
He also does extreme endurance sports, doesn't he?
Oh, he's an extraordinary guy. Now, Not everyone can be like him, but I think his case can inform a lot of people to think about their health in a different way and about their approach to statins, cholesterol, and informed decision making.
Great, thank you. We've had quite a few questions about statins, presumably from people that are on statins and concerned, obviously, that they're getting a little bit of a bad rap. But are there certain situations where you would still recommend statins to patients in general? And if patients aren't experiencing side effects, should they really worry anyway?
Okay, great question. So the default position, this is not about, it's about informed shared decision making. So, you're going to get different responses to patients when I have this discussion. So if you've got the heart attack patient, to be honest, my personal view on this is that really the only people that should be being offered statins, in my view, are people who've got significant heart disease diagnosed, okay, who've got angina, who've had a heart attack. And certainly, I think to some degree, people with familial hypercholesterolemia, who've got genetically very high cholesterol levels, that's where the people we should have the default of offering it them. But even in that situation, we need to be open and transparent with those patients. Say this is what the absolute benefit for you likely is. Whatever it is, 1 in 83 for death and 1 in 39 for preventing a non-fatal heart attack. And it shouldn't be at the expense of advising them first and foremost that probably what's going to be better for their quality of life and longevity is going to be a lifestyle approach. Statin is not a substitute for that. So we can combine both if you like. You can make a decision that you don't want to take a statin and just do the lifestyle. That's completely up to you. I'm here to support you in that decision-making process. That's what shared decision-making is. That's a more ethical way of practicing medicine. So that's where I would start from. In terms of the side effects issue, again, same sort of thing. If people are on a statin and they know why they're taking it and they want to carry on with it and they've not got side effects, I leave them to it, But I also inform them saying, listen, I want to make sure that you are also adhering to the best possible lifestyle you can do. And I'm here to empower and inform you about what the research says on this. And that's the kind of information what I would share with my patients. If they get side effects they're worried about, then again, really important to speak to their doctor. Often what will happen is the doctor will do one of two things: either stop the statin completely, go cold turkey for a couple of weeks, and the chances of it causing any harm for doing it for a short time is almost zero. Especially if you've got true side effects, it may well be zero if it's causing harm, rather than it being 1 in 10,000 or something like that. And usually you will find out within a few days to a couple of weeks whether that symptom disappears, and it's probably the statin. If it doesn't change, what I say is then have a think about, go back on the statin or go in a lower dose, and then carry on. So that's usually what I say with my patients. And if people are worried or concerned, then go and have a discussion with your doctor. Your doctor cannot force you to take a statin. It's your choice ultimately. But obviously people, they trust their doctor, and a lot of people will then decide that we'll go with the doctor's opinion, and that's completely fine as well.
Great, thank you. We've had a lot of questions on diet, and there's no way that I'm going to be able to read out individual questions. So I'm going to try and get you to answer some of the questions that I've kind of combined together. So I have an interesting question on what's the main difference between a keto style diet and a Mediterranean style diet? Should I be concerned about how much red meat I'm eating, as there's a apparent risk with colon cancer?
Okay, So, there's lots of information available, open access online around differentiating keto and what level. I mean, in essence, it's, usually people need to get their carb consumption for less than 50 grams a day, at least, often less than 25 grams a day. If you want to start a process of going ketogenic diet, I suggest that you look at a website called dietdoctor.com.
Yeah. And
they can guide you through that. Certainly something you should speak to your doctor about as well if you're going to be doing that. The Mediterranean diet, let's be very honest and open here. The traditional Mediterranean diet was high overall, total carbohydrate was high carb. It's not a ketogenic diet, okay? There is a ketogenic Mediterranean diet, which is an evolution or, a component of the Mediterranean diet that people do. But the traditional Mediterranean diet was actually, lots of whole fruit and vegetables. Depending on which country you were in, there was, bread, pasta, rice. But interestingly, the type of bread that people consumed in traditional Mediterranean diet going back to the 50s and 60s, by the way, not the Mediterranean diet now. And the reason we talk about the Mediterranean diet is because, the heart disease in the Western world peaked in the 1960s and 70s. And Mediterranean countries had much lower rates of heart disease than northern latitude countries like England, some of the Scandinavian countries, the United States. The amount and type of pasta that people consumed was very different as well. So, it was, and there was no ultra processed food and very little sugar consumption. So it's a very different type of diet to the one that, we have evolved from that. But I think if someone has perfect metabolic health, they're not consuming ultra processed foods, they're having little sugar, and they're having, sourdough bread that is freshly baked, and they're having whole grain pasta, and they're eating all the other things, it's unlikely to do them any harm at all. The problem is if you are pre-diabetic, if you're a type 2 diabetic, then you have a sensitivity to carbohydrates, and particularly the starchy carbohydrates, so breads, pastas, etc. And your approach for managing those kind of patients is very different to somebody who is physically very active and metabolically healthy, right? So I think that we need to understand that nuance here. It depends where you're starting from and what you want to achieve, and also what your dietary preferences are. To answer the question about colon cancer, so the data on colon cancer and red meat is more specific for processed meat. And to break it down, it's because of something called nitrosamines. It's not nitrites or nitrates, preservative. It is a combination of these nitrites in, things like bacon, processed, that when cooked or when they combine with the amines, the amino acids in meat, they produce something called nitrosamines. Nitrosamines are carcinogenic. But to put it in perspective for people, eating 2 rations of bacon, a couple of times a week is not, significantly associated with developing colon cancer. The risk is if you're having it regularly over a lifetime, that risk is probably about 1 in 100, 1%. Let's give people perspective here. But I would still advise people to cut out the processed meat altogether. If you're going to have red meat, it can be absolutely very much part of a nutritious, healthy diet. It should be not the base of the diet, in my view. I know there are people following carnivore and all that kind of stuff. That's something else. That's not my area of interest or expertise. I know there are good people out there that, or people that are benefiting from this in terms of the short term, but the long-term data still seems to fit with, a variety of whole fruit and vegetables, some meat, plenty of fish, eggs, dairy, if that's what you want to have, nuts and seeds. That should really be the bulk of your dietary plan.
Great, thank you, Aseem. I've got one here on a completely different subject. What do you consider the current gold standard test, private or NHS, to determine the state or health of your heart and major arteries in someone that's asymptomatic but has already had a heart attack? So someone's obviously concerned about monitoring their heart health.
Yeah.
Post MI. How would they go about that?
So listen, this again is a little bit more, I've got to give you a very general answer because it obviously depends on the individual. In general, the general default is you don't, if you've got your conventional risk factors you look at, okay? You adhere to the lifestyle. If you've not got symptoms, if you've had a heart attack, we wouldn't really recommend any routine testing, okay? If some patients come to me and they're really worried and they want some reassurance that everything is stable, then the best non-invasive test if you haven't had a stent, although you can still do it if you've got a stent, there's some caveats there, but it's not recommended if you've had a stent, but you can still do it, is a coronary calcium score.
Yeah.
And for some of my patients, I would say, once every 3 years, for example. And I do see some patients who are in that situation, you find that their calcium score, which is really a marker of the disease process going on in the arteries or developing, remains very stable or hardly changes over a period of 2 to 3 years. And they're very reassured because it means that the lifestyle changes they've implemented have stabilized the situation in their heart. And that's what we want.
Great, thank you. And also, are there any, we've touched on this before, but are there any breakthrough treatments or procedures on the near horizon for reversing atherosclerosis?
I'm working on it.
There we go. So
but there's no treatments in terms of medical treatments.
No.
But the data that's there does actually suggest a combined lifestyle approach of diet, a very specific amount of exercise, moderate activity, and reducing stress through meditation. So the data that's published that suggests reversal of coronary artery disease combined a number of factors together. And I'm writing about that at the moment, and just watch this space, but hopefully something will come on that, out on that soon.
Great.
By the way, just to mention very briefly as well, what's interesting is, so we know that increasing coronary calcium scores in asymptomatic people is associated with a greater likelihood, certainly if it's over 100 to start with. If it increases by more than 20%, you're more likely to develop a heart attack than if it's less than 15% per year. But interestingly, data shows that statins do not change the coronary calcium score.
No.
Do not reduce the coronary calcium score or the progression of coronary calcium.
I actually read that they can actually increase the coronary calcium.
It can. Some people think that actually is a good thing, but actually I've looked at the overall data and it's very, debatable, because microcalcifications actually are more associated with plaques, the underlying narrowing blockages in the arteries rupturing. And the more dense calcifications are less. And what's the statin doing? Is it more of the dense or whatever? So when you look at that sort of data and it's kind of a bit mixed, it means it probably isn't having any particular effect. But again, I still think there's probably some anti-inflammatory, anti-clotting effect of statins, which seems to be more beneficial in people, certainly people with heart disease, and very minimalistic at best in people without.
So a number of people have
talking about side effects. Yeah. Sorry.
A number of people have asked if they optimize their diet to such an extent. These are cardiac patients that are on multiple medications, such as blood pressure tablets, statins, antiplatelets. Is there any possibility, because they've changed their lifestyles to such an extent, that they might be able to come off some of those tablets in time?
Yes, absolutely. Okay. I've seen people come off their BP pills. People who've been on BP pills for 10 years within 3 months of changing lifestyle. I've seen that in my NHS patients. I've also, I've seen people send their type 2 diabetes into remission within, people who are on insulin for 10 years and taking other medications for their type 2 diabetes. I've seen within 28 days of just changing diet, basically a POPI diet, essentially. Yeah, I'm going to be here to promote the POPI diet. Yeah. But no, there are different, people can do different things and have different approaches. By the way, I think it's important, again, I just want to make sure that I'm being very open and transparent here. Declarations of interest, I have no relevant so-called conflicts of interest. I don't take any money from the pharmaceutical industry. All my publications I do myself. I'm not attached to any particular institution that funds any of the analysis or articles I write. All of the publications I do in the mainstream media press, certainly in the last few years, I've asked them to give the money to children in need, so I don't get paid for that. But I obviously have published 2 books, so yeah, I mean, if people think that's a relevant conflict of interest or declaration, it's important for me to just share that, people know that. Yeah, anyway, I just thought I'd mention that. But I don't say that people should be doing one thing or another. I think things evolve, and I try and look at things as independently, and then advise and plan patients according to that.
Great, thank you. For those people that don't have any symptoms and are concerned about their cardiovascular health, who should go and seek out a coronary artery calcification scan. And we've also had a question around that is, does the scan, people are concerned about soft plaque, will the scan...
Yeah. So coronary calcium score, first and foremost, it's really important that it's only really relevant, as in it becomes reliable, if you're a male over 40 and you're a female over 50. So there's a problem. I think if you're not in those age brackets or whatever, it's not helpful or reliable for lots of reasons. So I wouldn't recommend it under that age.
Okay.
To start with. I wouldn't be fear-mongering and telling people to just go. I think, listen, everyone is going to be different. If you've got a very strong family history, you've had a lot of people dying prematurely, your first-degree relatives under 60 dying from heart disease or diagnosed, you should be aware there's a likelihood you may have a genetic predisposition, a family history, and that should make you more alert to your general lifestyle stuff. But I think I would then come back to those basic things, which are very simple and straightforward, is your waist circumference. What's your blood pressure? What's your blood glucose levels, average HbA1c, what your triglycerides, HDL. I would focus on those first and foremost. If beyond that, and you're a bit older, and you're very worried for whatever reason, then you can get a coronary calcium score. It's not something that would be available in the NHS. You'd have to pay for it privately. But I would try and avoid that if possible. But again, it's all individual based. It's something that you can discuss with your doctor if you're really worried, and then he can advise you. Other than coronary calcium scores, there are other tests that can be done, like treadmill tests, for example, but there again, you get we call a lot of false positives from that. So everything should be guided by your risk factors and your family history. But I think what everyone can do, to give them some idea, is you can go on the Q risk calculator thing online, and you can plug in certain things and your age and blood pressure and all that kind of stuff. And that will give you maybe some reassurance that your risk of a heart attack or stroke in the next 10 years is this. And you might, people come back on it and they're really pleasantly surprised and like, oh my God, my risk is only 1 in 200. Well, okay, fine. For many people that gives them reassurance. They don't need to worry, especially if you've not got symptoms. You're not getting chest pain when you're walking around, for example. And if you are getting those sorts of symptoms, then you definitely need to see a doctor urgently.
Great, thank you. I've got a question on medication, just a general question. Someone that's overweight, pre-diabetic, been put on beta blockers, concerned that the beta blockers might cause weight gain.
Sorry, the question is about beta blockers causing weight gain?
Yeah. Someone that's trying to lose weight, pre-diabetic.
I mean, beta blockers probably can do. I can't remember off the top of my head all the side effects of all the drugs.
Yeah.
So I can't really answer that question, to be honest.
That's fine.
But but that person, everyone who's prescribed a drug is given usually an information leaflet, which gives you pretty much all of the common side effects on there. So I think if you can look that up and if you can find that, then he might be able to. And if he's worried that the beta blocker is causing weight gain, then he should discuss it with his GP. There may be an alternative for him than taking the beta blocker.
Great, thank you, Aseem. Got a question here on a slightly different subject. Are you aware of any doctors in the UK that are using diet to treat mental illness or mild cognitive impairments, including dementia?
No.
Oh, okay.
We know there is some data that randomized control trial done in Australia showed, I think within 6 to 12 weeks, they showed significant increases in depression scores for people who adopted a low carb Mediterranean diet. Okay, so I think that diet does have an effect on mental health. Data is still limited, but certainly if you improve your physical health, everything's interrelated, then mental health is also very much affected by that. So indirectly, your mental health is likely to be, in a better place if your physical health is better. Absolutely.
Great, thank you, Aseem. We've had a question relating to the Q-risk calculator. Basically, how accurate is it in determining cardiovascular risk?
It's pretty accurate. I mean, it's not perfect, but it's a nice guide. All of these things are guides. I remember I told you at the beginning, medicine is not an exact science. Some people think it is. It's not. In fact, what I'll say at this point, Richard, is, and I wrote about this, you can look up the article if people are interested in reading it. if you just put King's Fund and put cardiovascular health and my name, is that, modern medicine, since 1850, we've added about, 40 years to average life expectancy in the Western world. Of those 40-year increase in lifespan, modern medicine, okay, has contributed to about 3.5 of those 40 years. Most people don't know that, right? And the point I'm making is that even these risks and these calculators are a guide, and it's not a substitute for the whole consultation, history, discussion with that patient, looking at everything, taking all these different factors into consideration. But it's a general guide, yeah. So, but it's probably relatively pretty accurate for most people as an average risk from looking at those factors. There are things that are missing, which are not easy to measure, like psychological stress, for example. And I think some data does suggest that if you've got significant chronic psychological stress based upon personal circumstances, and the two biggest sources of stress for people are either work or relationships, then that as a risk factor over time is probably the same as having high blood pressure or having type 2 diabetes on its own, right? So it's a significant risk factor. And it's something that we haven't properly addressed as a society. It's not something we've addressed properly as individuals. And the data suggests at the moment, and obviously COVID-19 is a bit of a anomaly because, but even pre-COVID-19, is that in society, generally chronic stress levels are increasing. There's more anxiety amongst kids. A lot of it is driven by social media, unfortunately. There's something called status anxiety. People are constantly comparing themselves to others based upon fake, brittle popularity of people photoshopping and doing all sorts of stuff, posting the best version of themselves, and all of these sorts of things, I think, is affecting people mentally adversely. And I think social media is something people need to massively minimize their use of.
Great, thank you. We've had a lot of questions around diet, but this is a very generalized one. What's your own opinion on veganism?
Oh, that's a very general question. So veganism, people become vegan for different reasons. The original vegan movement was more a religious-based movement.
I'm guessing,
and I completely, I understand that.
Yeah.
Sorry, go on.
I think it was more around a nutritional point of view rather than the ethical reason for being vegan. What were your thoughts on the vegan diet nutritionally?
On the nutrition perspective, it is a nutritionally deficient diet because you remove animal products. Then your majority of vegans are not going to get enough B12, and often other things like iron and vitamin D as well, which obviously affects everybody anyway now. And obviously making sure you get enough protein. So there's quite a lot of issues with it, but you can theoretically have a healthy vegan diet, absolutely. But it does involve use of supplements.
Great. And so I'm just...
We've got about 15 minutes, haven't we, I think, for...
Yeah, I've got loads of questions. I'm just trying to not make them too similar. I've just got one come up here. There's one here on what's your thoughts on taking low dose aspirin as a preventative measure after a mini stroke?
Yeah, there's evidence of TIA and taking low dose aspirin, but again, it should be, everything else should be looked into consideration. If some people have a very high risk of bleeding, for example, we're a bit more cautious with low dose aspirin. But again, it's a bit of a very specific question. Aspirin in general for me is a great drug. Okay, it's one of the best drugs we've had in managing heart disease, in treating heart attacks. Relatively safe low dose aspirin. It has an antiplatelet effect, so it affects blood clotting. Overall, about a 1% risk of it in someone's lifestyle causing them a significant stomach bleed. So that's the downside of it. But if you don't have risk factors for bleeding in the stomach, and had ulcers in the past, for example, then that risk is much less.
Great, thank you, Aseem. Someone's concerned about cholesterol, high cholesterol. So we talked about cholesterol not being the be all and end all of, health. Someone's concerned about can having high cholesterol cause gallstones, and can statins help prevent that?
Not aware of any evidence on that at all. Not
Okay.
aware of it.
Okay, this is a good one. Are we getting anywhere with changing hospital food and the multitude of cakes, processed cakes? Is healthier food now being made available to NHS staff? This has to be a priority.
I think there's inconsistent depending on which hospital you're at. So Tameside General Hospital, which was my local hospital where I grew up, I gave a talk there as well. They've started to, they remove sugary drinks, for example, from their canteen. It's quite small, but certainly, it's starting to have an effect. It's still a massive problem, sadly. 75% of food purchased in hospitals from staff, patients, public members who are visiting is still unhealthy. Confectionery, crisps. I mean, it's pretty shocking, to be perfectly honest, knowing what we know about how adverse diet affects health, and we are actually selling and promoting these sorts of products in hospital is pretty staggering. So we've still got quite a long way to go, unfortunately.
Okay.
But I managed to get the BMA involved, and the medical oncologists, I work with them to make it part of their policy. So NHS England even have pretty much said that we need to get, improve the food for hospitals. So it's now up to, I think, ultimately chief executives of the hospitals to influence contracts about the types of foods that's coming to the hospital. So if people are not happy, everybody has a voice. We live in a democracy. They have to respond to you. Then you need to write. Don't expect other people to do it for you. I mean, I'm doing a lot of work and trying to, implement the 7 Nolan principles and leadership and influencing people. But it was going to be much greater. It's going to have much greater effect and be catalyzed if all of us, took some responsibility to help change that system that affects our friends, our relatives, our kids. We all have to do something, and don't feel that your voice is not important or won't be listened to. You can just find out the email address of the chief executive of the hospital and make your views known to them and say, listen, I think this is unacceptable. And if you want to cite and send links to, the BMA, you can look all of that up online and put my name there if you like, that this is part of their policy. Why are you still selling this? You find this unacceptable, it's not healthy, it's detrimental to people's health. And you can cite those medical organizations saying that they support that we should improve hospital food. Why are you not doing so?
Great, thank you, Aseem. And actually, I know someone that's done that and had a good response. Rosemary Wellman, who's a patron of the Public Health Collaboration and a co-founder of the Lifestyle Physiologist. She's actually written to the main hospital in Sussex, and she got a reply, and so that sets something in motion.
Fantastic.
Yeah.
Good for her.
Going back to diet, a lot of people interested in trying different ways of reversing coronary artery disease. What's your view on Dean Ornish's approach? Even though it was the original research was done some time ago, is that something that we should be looking to follow?
So I think the Dean Ornish, I think, has done some really great pioneering work really to kind of push or introduce that initial concept of heart disease reversal. With his particular plan, it was a vegan diet, but it was a combination of smoking reduction, exercise, and stress reduction. And there was definitely a reduction in progression. There was some very, very slight, from his small study, suggestion of regression or reversal. The only, I think, a reasonable criticism of that is that we don't know what specifically of those different components had the biggest effect. And it may have been a combination. I suspect it's probably a combination of things. But if we replace that vegan diet with a Mediterranean diet, would we have had the same benefit or seen even greater benefit? We don't know the answer to that. My guess is, with what we know, because it was a very high carbohydrate diet, is that there's probably a better dietary approach than that adopted by Dean Ornish. But it hasn't been tested or proven yet.
Great, thank you. This is a general question, but I can follow on from it. What are your thoughts on intermittent fasting? I know that's a very generalized question, but
it's up to individual people. I think there's no, again, it's something, depending if you're taking drugs and medications and stuff, you've got to be careful. If you're on medications, before you start doing it, speak to your doctor, because you might have to change doses, for example, diabetes drugs, if you're going to be fasting for a long period of time. Jason Fung is my friend and colleague in Canada who's written about this and done a lot of publicity around it. And some of my patients find it very, very useful and beneficial. And there are different things. In fact, the immunity plan, I write about that a little bit in terms of the way you can approach that, over several weeks, build it up gradually from a 12-hour fast to 14 hours to up to 16 hours. So I'm pretty open to it. I think a lot of people get helped by it. You don't have to do it. I think a lot of the data shows that if you're following a healthy dietary pattern, in terms of weight loss anyway, there's no extra benefit from intermittent fasting.
Great, thank you. Also, for those people that are physically active like myself, have you ever come across patients that have have attempted to go really low carb, are doing very high levels of exercise, and actually found that they've encountered problems going very low carb or almost approaching ketogenic diet, where they're not actually in ketosis, but they're going very low carb, but also placing high demands on their body? Have you encountered any?
Yeah, so if you go low carb, and especially if you're not used to it, there might be a slight increase in cortisol, stress hormones initially, as your body's getting used to it, right? If you're not in ketosis, and that means you're not now adapted to use fat as your primary source of energy, but you're still getting relatively low carbs and being very physically active at the same time, you end up in a situation of no man's land, basically. And in fact, I was there at some point, and I found, and I'm very active, most of my life. And I found that I needed to have more carbohydrate just to make sure that, combine my resistance training with my cardio, whatever. So for me personally, ketogenic diet, my patients are, a lot of patients swear by it, so I support them on it. But for me personally, ketogenic diet didn't suit me. Okay. So I'm more Mediterranean low carb, less than 40% of calories for carbohydrates, little starch, lots of fruit and vegetables. I calculated this, and this is by default, and maybe I'm lucky because I'm Indian origin, so I cook a lot of Indian food, and with the greatest respect, I don't think British food is comparable in terms of taste when it comes to Indian food, but of course I'm very biased on this. So there's a lot of great Indian vegetarian food, and I probably, mixing everything I have, I probably get through at least 7 to 10 portions of fruit and vegetable a day. Easily. And that's still being low carb. So so to answer the question, Richard, if you are highly stressed and you're going low carb and you're very active, it might actually make your stress levels worse and make you feel drained, and that can happen. So it's just something to be aware of. Yeah,
and that has actually been my experience. Just thought I'd throw that in there because at one time I was doing, well, I still am doing high levels of exercise, but at one time approaching ketogenic, and as you say, I wasn't fat adapted, so I was in that no man's land, and I wasn't feeling good on it at all. But fortunately, we had that chat, didn't we? I wonder how many people have been in that place.
Yeah, absolutely.
Going back to heart-specific stuff now, would you recommend private advanced lipid testing to test, for example, LDL particle size and number? So
would I recommend?
Would you ever recommend private advanced lipid testing?
No, absolutely not. Don't need to waste yours or spend extra money unnecessarily. Some of my patients ask me about this. Your triglycerides and HDL is a marker of your LDL particle size most of the time. And that's a very cheap test you get done anyway. So if your triglyceride to HDL ratio is less than 2 and ideally less than 1, then it's very likely your LDL particles are in the good type of particles are type A, large fluffy ones that are less likely to damage the arteries of the heart.
So it's the type B, the small dense ones that we're concerned about, but what you're saying is the triglyceride to HDL ratio is the most important.
That predicts the particle size.
Yeah. And just on the note of ratios, because we've had a lot of questions around high cholesterol in general, and I think people are quoting their total cholesterols. You touched on it near the beginning of the presentation. Could you just explain again briefly about why the ratio, the total cholesterol to HDL ratio, is probably the most important one to look at?
Because that's what all of the studies showed on Framingham when they looked at that. That's what's used. This is a problem. People are going around being treated for high total cholesterol when they're so, for example, you could have a patient who has a total cholesterol of 4 and a HDL of 0.8. Okay, 4 divided by 0.8 is 5, right? Who is then told, you know, or under the impression from either their doctor, whoever, your cholesterol is low, great, okay? But the total cholesterol to HDL ratio is a little bit high, it's 5. And you get another patient whose total cholesterol is, say, 7, and the HDL is 2. 7 divided by 2 is 3.5. That person's ratio is way healthier than, or you know, certainly less risky in terms of long term than the person who has a total cholesterol of 4. This is the problem. So it's a total cholesterol to HDL ratio that needs to be looked into, not high total cholesterol. That's not as important or anywhere close to. And this is the problem. And the reason that total cholesterol is used a lot of the time is because people see this as a surrogate for LDL, and people are worried about high LDL. But LDL, in my view, and I've not seen anything to contradict it, and I've looked at this research extensively and published on it, looking at all of the data, even people, older groups, younger groups, is not really a significant, doesn't even become a significant risk factor unless it's above 4.9, which is not most people. And even the people who are above 4.9, certainly, you know, 70% of women and 50% of men with familial hyperlipidemia will not develop premature heart disease. So I have a lot of people who have got very high LDL, especially I wrote about this in, so people want to have another read to get their head around this a bit more. Yeah. Again, open access, free, I didn't get paid to write it. I'm not, you know, got a lot of interest and impact. One of the best articles I've written on this to summarize all of it, and it will probably shock you, by the way, there's some dramatic conflicts of interest that I put in there, which people will, when they get to the bottom around side effects, will think, you know, what's going on. If you Google and look up European scientist, okay, and put in, do statins really work? It's an article written by me, and it also gives a background why I coordinated the calls for a public inquiry into statins with the editor of the BMJ and many other people, you know, eminent people. I make the case for that statins inquiry about question marks on statins and about cholesterol and LDL and everything that I've spoken about in that article. So read the article from beginning to end. You won't regret it, okay? Do statins really work? Aseem Malhotra, European scientist. Read it from beginning to end. And it covers actually a lot of that talk, of the talk we've covered today. A lot of your questions will be answered from that.
That's great. I'm glad you said that, Aseem, because we've had tons of questions around statins and can't possibly read them all out. We're running out of time. Just got time for one more question, I think.
Great.
This is from Karen Porter. Hi, Richard and Aseem. Is there any agenda to address the education on diet, nutrition, and overall health in schools, encouraging responsibility for choices made? You know,
so I've campaigned on school food actually for quite a long time. When I started off, one of the things I did very early on is I met Jamie Oliver. That's another interesting anecdote in itself, which I'll save for another time. But I, with Jamie, you know, I kind of got Jamie on board in one specific thing I did, which was like a BBC, you know, news thing in 2012, where I managed to get Jamie Oliver, Stephen Gerrard, many senior doctors, pediatricians on board to say we need compulsory nutrition education and cooking skills to be introduced into schools. And then it's been reiterated a few times with various organizations and groups. But again, there's a bit of, you know, it's not easy to get these things implemented. And I think people need to keep pushing for it, you know, do it locally to encourage, to make sure we have, you know, really good nutrition standards in school, as well as making sure that, you know, to be honest, kids shouldn't be bringing in, different schools have different policies, but kids really shouldn't be bringing in junk food, in my view, into school, you know, crisps and chocolates and all that kind of stuff. We should just get it out of that food environment. So there's still, again, I think there's still probably work to be done there. But it's certainly something that's recommended by the Academy of Medical Royal Colleges in their obesity report that I was involved with published in 2012. You can look that up and have a read of that. It's called Measuring Up. The doctor's prescription to tackle the obesity epidemic, 2012, Academy of Medical Colleges, free open access, and have a look at that and see what we wrote there.
Great, thank you, Aseem. And we've just about run out of time, so just wanted to let you know that I've had a few comments from people just saying, sending their thanks to you for changing their life. Had quite a few of those, so thanks, Aseem. You've been an absolute life changer to me, and lots of those coming in. Thought you'd like to know that.
That's very nice. I just want to say that, for me, it's a collective effort to sort this problem out. We all have to work together, doctors, patients, policymakers. What we're really striving for, and what I try and do, is have this realization that we need a revolution. And to get a revolution, you have a grassroots movement, people working in communities. And if you combine that with top-down change, and where they meet in the middle is when you have the revolution. So what I do is to combine things through that social movement, through social media, through the grassroots, to informing the public and patients through the mainstream media, but simultaneously trying to influence the doctors, policymakers, politicians as well. And it's really important. What really inspires and keeps me going is that patient feedback and public feedback. So thank you very much for that. My patients are who inform and sustain what I do.
Great, thank you, Aseem. And we're all really grateful that you've joined us today on this webinar. And I'd like to just personally thank you for taking the time out to do this. We hope that we will be able to do future webinars on perhaps more specific topics, rather than kind of more generalized ones, possibly slightly shorter ones, but we'll let you know about that. Just for all of those that have asked the question, this is being recorded, and we will ensure that those people that haven't been able to watch the whole thing live will get sent the recording over the next sort of 48 hours. That you should receive that. So just thank you once again, Aseem, for joining us, and thank you everyone for signing up, and I hope you enjoyed the presentation, and stay healthy, and we'll hope to see you soon. Bye everyone.